Welcome to The Explainer. If you work in medicine, you see swollen legs pretty much every single day. But what is really going on under the skin? Well, today, we're going to build a clear clinical framework to demystify edema, helping you turn that common sign into a confident diagnosis.
So you're standing at the bedside, and you see those swollen legs. It's a classic puzzle. Is it the heart, the kidneys, the liver? It can feel a little overwhelming. But don't worry, we're going to build the mental model to solve this efficiently and with way more confidence.
Okay, first things first. Before we can even begin to figure out the why, we have to be crystal clear on the what. What exactly is edema?
It's actually that simple. It's just fluid that has left the bloodstream and is now pooling where it shouldn't be, in the surrounding tissues. So the real question isn't what it is, but why on earth it's happening, and that's exactly what we need to figure out.
Now listen up, because before your mind even jumps to thinking about the heart or the kidneys, this right here is your single most critical decision point. It's the fork in the road that is going to guide your entire diagnostic journey.
So think of it this way. Is this a plumbing problem in just one room of the house? Like a clogged drain in a single leg? That's localized. Or is the main water pressure system for the entire house on the fritz? That's generalized. For today, our focus is squarely on those systemic, generalized causes.
Okay, so we're talking about generalized edema. Now we have to ask the really fundamental question, why does this fluid shift happen in the first place? What are the basic forces at play inside the body that are going haywire?
I want you to picture this as a constant tug of war happening in every single one of your capillaries. You've got hydrostatic pressure, which is driven by the heart, and it pushes fluid out. And on the other side, you have oncotic pressure, which is created by proteins like albumin, and it acts like a sponge, pulling fluid back in. Edema is simply what happens when that push gets too strong or the pull gets too weak.
And this right here, this is a hugely important concept that trips a lot of people up. Get this. The body doesn't actually have a sensor for its total amount of fluid. Nope. It only senses how well its arteries are filled, what we call the effective arterial blood volume. And if the body thinks that volume is low, it smashes the panic button, setting off this powerful cascade to hold on to salt and water.
Now, I know this diagram looks a little complicated, but it shows something really fascinating. It shows the vicious cycle that gets started in diseases like heart failure or cirrhosis. See, the body fundamentally misinterprets the problem, and its solution to fix it actually makes everything so much worse. Let's trace it out. Just follow along with me here. So, whether it's a weak heart pump or leaky dilated blood vessels in cirrhosis, the end result is the same. The effective arterial volume drops. The body basically screams, "Hey, we're running dry over here," and it activates the sympathetic nervous system and the RAS system, two incredibly powerful hormonal systems designed to crank up blood pressure and hold on to every last drop of fluid. And this is the final common pathway. The body is desperately trying to refill the tank, but the real problem, the weak heart or the low protein, means that extra fluid can't stay in the blood vessels. It just gets pushed right back out into the tissues, making the edema even worse. It's a vicious cycle. So now that we totally get the science behind it, let's look at the main culprits. How does all this pathophysiology show up as the big three systemic causes that you're going to see all the time on the wards? This is awesome. This is how you start to solve the case right at the bedside. You ask yourself, does my patient get short of breath when they lie flat? That should make you think heart. Do they have a swollen belly and yellow skin? Well, that points to the liver. Are their eyes all puffy in the morning? You got to think kidneys. These classic clues are like your compass, pointing you in the right direction.
Now, while you should always think about the big three first, please don't get tunnel vision. A really good medication history is absolutely crucial. Common drugs like NSAIDs or certain blood pressure meds can be the culprit, and you should always keep things like nutrition and thyroid function in the back of your mind.
Okay, so we've covered the what, the why, and the who. So let's bring it all home. Let's put it together into a simple, actionable strategy you can use with your very next patient. This is it. This is your core algorithm, your mental checklist for every single time. Step 1, is this a local problem or is it systemic? Step 2, what clues is the patient's story and my physical exam giving me? And step 3, what simple labs can I get to help confirm my suspicion? It's that straightforward.
And this really just highlights the power of your fundamental clinical skills. You often don't need a barrage of expensive, complicated tests right off the bat.
The answer is usually hiding in these initial steps, which saves time, saves resources, and gets your patient the right care faster.
And that right there is the key takeaway. When you see a patient with edema, don't just think fluid overload. I want you to think deeper. Ask yourself, what is the body signaling to me? Is the pump failing? Is the protein factory broken? Or is the filter clogged? Because by understanding the signal, you can find the source of the problem, and that's how you can truly help your patient.